I don't know how to whistle. Okay. I would like to introduce to you Joyce Norman. She has more initials behind her name than there are letters in the alphabet, I've decided. She is going to speak to us today. Well, first of all, she's from Tucson, Arizona. She received her nursing degree from Maricopa Community College in Phoenix and bachelor's from University of Phoenix. She attended the Tucson Medical Center and has been board certified since 1985. She's a member of the Tucson affiliate of the Wound Ostomy Continence Nurses Society and a diplomat in the American Professional Wound Care Association and a member of the Association for the Advancement of Wound Care. She has many, many years of clinical experience, including 25 years in the acute care setting as a consultant, and has been involved in home health care, skilled and hospice care settings. She has practiced the full scope of wound ostomy continence nursing for 28 years and has lectured for over 27 years. She's done a lot of traveling to Billings and to Montana, so let's please welcome her.
Thanks. Let's see. Details. Here we go. All right, how's that? People in the back wave? Good, good. Alrighty. Thank you for inviting me to speak. I've told some of the planning committee with this that had I not been doing this, and all those letters, by the way, they're just related to wound care. It's my life, it's what I do. But had I not been taking this job to go around the countryside teaching wound care, I would probably be full-time in hospice and palliative care. So it's definitely an avenue that I very much support and enjoyed working in, and commend all of you for this as well. I didn't catch the lady that spoke before me, her name, but what a delightful colleague to have in your community. Okay, let's get going. Somebody asked, what does staging mean? Staging is the pressure ulcer system. And maybe that summarizes my title even more. It's that sometimes we make this much more difficult than it needs to be. And so I'm trying to just simplify this process, especially as we're all trying to communicate well with one another. All the disciplines and all the healthcare settings are utilizing the same terminology now. So this has been a process that everybody kind of caught up in 2010 with using this same system, but we'll go forward with that. Now, I would like to know if there's anyone in the room who has been practicing in healthcare since the mid-'80s or before. Okay, a few of us. I see some that have been practicing. I will tell you, you are the first group this week to raise your hand. The longer I do this, the more I've been a WOC nurse for 28 years. Many times the students in my class aren't that old, let alone have they been practicing in healthcare for any length of time. So the reason I bring that up is that prior to the mid-'80s, there was no such thing as wound care. So when you're hearing all of this information and trying to incorporate all these great practices and ideas into your daily practice, remember a lot of this is relatively new. And for those of us that have been practicing a long time in healthcare, the things that we do now didn't exist when we went to school before the mid-'80s. There was no such thing as hospice in this country. There were things as home care nurses. If you were seen in your home by a nurse, you were what was called a community dweller, and you were involved in the public health system. Skilled care didn't exist in the settings. What do we used to call skilled and long-term care? Nursing homes. And what were nursing homes for? Old people, not necessarily just old, but it was a place where people went because they needed custodial care. They could not care for themselves in their own home, nor could their friends or family. So they needed to go somewhere to get that 24/7 care. So these things have all evolved over the last few decades, if you will, and really looking at the evidence-based practice that we'd like to base our information on, we're talking really in this new century. This is actually a nurse, by the way, this slide. This is a nurse working on a child in her kitchen. Now, I don't know what this nurse is doing, and I really don't want to know. What the point of all of this is that, first of all, we don't go to the kitchen for skin and wound care needs anymore. If you can get something in the kitchen, it's probably not been approved by the FDA as safe and efficacious on your patients. So we'll just take this as an archival photo. Welcome to the new century. We are in the 21st century. Welcome to the new era. Healthcare reform has started to gently roll out this year, January 1 of this year, with some of the new programs and better understanding all of these things. But what is going to be paramount in this time as we see how these programs unfold and how well they really will work and help us to be a more cost-effective and cost-efficient system is that it's going to really work well based on the communication we have with one another. In reading some of the literature and going to some classes about these things, one of the things that they do state time and time again is that the people that will make healthcare reform successful are nurses. Nurses are better than any other discipline in healthcare at standing back and looking at everything going on with the patient, making sure that they're not just focusing on one little specialty, but looking at all of the things that impact the ability of that patient to get better or to have good quality of life issues. Remember, it's all about the outcomes. What are our goals? What are our outcomes going to be? When we look at this, and pressure ulcers are such a big topic of discussion is because they are the single most expensive item in healthcare. If we can just get pressure ulcers under control, we'll be able to do a lot of other things as well. When you look at these numbers, I don't know how many of you study skin and wound care issues, go to other wound care programs or read wound care journals or any types of things, but there's lots of information out there about this. And one of the numbers that you will see is that the average cost to heal a full thickness or stage 3 or 4 pressure ulcer is somewhere around $40,000. And those numbers come directly from Medicare. When they start looking at the numbers that the billions of dollars spent on pressure ulcer care every year, you can see from 2007 it was around $11 billion, 2008 it went up to about $15 billion. And the problem with this number, with all the focus on pressure ulcer care, pressure ulcer prevention, better understanding of all the things that we do, this number is not going down. This number has kind of flatlined. So this is why the big focus in making sure everybody understands what it takes to prevent these things and improve outcomes. Even in the end-of-life situation, in the palliative care arena, this is not what you want to die from. This is not what you want your friends and family to die from. This is very painful, very debilitating. There can be odor issues and all of the quality of life. Dying with dignity kind of goes out the door when these things come about. People are doing research for us. I think one of the great things in healthcare is that there's so many people working together to give us all of this research. So for those of us that maybe don't like to do research, I personally don't like to do a lot of research. I'm not a statistician. I'm not really a very good scientist in a lot of arenas. But I do like reading about what they come up with and how we can incorporate these things in our daily practice. And one of the things that there are several things that they're helping us to understand. One of the things is that 70% of all pressure ulcers will be in patients 70 years of age and greater. Just getting older causes people to be more at risk. So do you have a patient population that's in their 7th, 8th, or 9th decade of life? That alone might be an issue for focusing more on their skin. And what we also know is that as few as 4% of patients admitted to a healthcare setting will that initial diagnosis be a pressure ulcer. So what are all the other, where are all those other 96% of patients with pressure ulcers being admitted to our healthcare settings? We know that only 12% are a secondary diagnosis. So why it's important for us to capture this information as soon as we possibly can, preferably present on admission to wherever you work, so that we can identify the problem, improve it, and this not be the reason somebody becomes septic or dies. All of our professional organizations, all of our state and federal organizations, everyone is on board with this information because it is such an expense with such poor outcomes. Medicare is looking at it because of the high volume, high cost, poor outcomes on something that is reasonably preventable. Okay, so lots of work being done there. The other thing, of course, is to understand not all wounds are pressure ulcers. And this is an area, one of the things that people are trying to figure out is why aren't the numbers, with all of the information being thrown at healthcare clinicians, why are the pressure ulcer numbers not going down? And one of the things they believe is that we have become so comfortable with this staging system is that we call everything pressure ulcers. We use the term stageable, unstageable, whatever stage it is, to describe a wound, even when it's not a pressure ulcer. And when you or your staff does that, no one comes back and corrects your charting. No one changes that information. So that information gets put in a medical record, and now somebody thinks that they have a pressure ulcer and we're supposed to improve it, when maybe in reality it's not. The other problem with that is that when we call things pressure ulcer and initiate pressure ulcer prevention programs, we may actually be denying this patient the care that they deserve. When they have some other disease, when we don't get them to the referral, to the referral source that can help them, we may be causing them to have problems that could cause them to become septic and have issues. So that's where a lot of the focus is being able to differentiate what we're looking at. Is it from pressure? Is it not? If it is, let's get it taken care of with pressure ulcer care. If it's not, where might they need to go? We know that lower leg ulcers are the #1 volume of wounds in the world. The leg ulcer, the venous ulcer, is the #1 wound in the world. When you walk into your patient's home or room, greater than 70 to 90% of the time, if they have a wound on their lower leg, it will be a venous leg ulcer. All right, these wounds are very easy to treat. We need to get them fitted for stockings. We need to get them taken care of, get them to their medical supply company that can help you with fitting and such, but we do not stage these. These are not pressure ulcers. The other issue, which of course is a huge problem, not just in this country, but in the world, are patients with diabetes. And we learned at a conference last year that I attended in the fall that by the year 2020, so in only 8 more years, 50% of this in this country will be diabetic or pre-diabetic. The numbers are staggering, absolutely staggering. When you think that currently 1 in 8 to 1 in 10 Medicare healthcare dollars are spent on patients with diabetes. Again, on wounds that are potentially preventable. What is the focus? What are we doing to educate? And again, not stage these wounds that maybe need to see the podiatrist, the podorthist, the medical supply person, your diabetic educators, your endocrinologist, you know, that other avenue of care that might be of more benefit to them. But again, just wounds that stage. So where do you and your patients fit in the healthcare continuum? I think one of the best parts about healthcare reform, there's 2 things that I really like about it. A lot of these things we don't really understand or know what's going to be the full impact. But the thing that I really do like about it is that it is going to be patient-centered care. We are now going to put the patient in the center of all of this, and what can we do as healthcare providers to help you? I think most of the room, I was looking at the sign-in sheets, most of us in the room are nurses. And I think most of us went into nursing because because we like to care for patients. We're nurturing by nature. We like to care for people. We like to do for people. The problem is that we can't be everybody's, best friend, mom, grandma, nurse, neighbor, whatever it is. We have to understand and learn a lot from our colleagues in the therapy arena. How many of you do I have any therapists in the room? Physical, occupational? Yes, sir, you are? Physical therapist, okay? When this young man goes into a patient's room or home, he doesn't go in and say, oh, it's okay, I'll do it for you, honey. It's all right, I'll take care of this for you. He thinks of it a little differently in the long term, in that what are your goals and how can I help you meet those goals? And we start thinking more creatively like that, is that here you go, this is your problem, and you have a problem, and I, as a healthcare provider and educator, can help you get better if you understand these things. And we're going to send you maybe to an acute care setting to get a comprehensive assessment, maybe a surgery, maybe labs or x-rays or biopsies or whatever needs to be done. And then they're going to just stay there for a few days. And then they're going to go to somewhere else in the healthcare continuum. Maybe they're going to go into a skilled facility because they still need 24-hour care, but not to the level of acute care, but they need those skilled folks, those wound care programs and those therapists and all those specialties that are now in these buildings. Maybe they don't need 24/7 care, and they can go back into their own home, and a home care nurse or a hospice nurse can come into their home once or twice a week and just to check on things. Maybe they don't need any services of that sort, and they could go as an outpatient. So we have to know where they fit. And then, of course, the end-of-life issues, where maybe this patient is just not going to get better. It doesn't matter how good we are, we're not going to be able to fix something, and maybe hospice and palliative care will be the best avenue. And we need to be realistic about that. That doesn't mean we failed them. That means we're getting them to the healthcare provider that can provide them with the best resources and provide the best care. Okay, I love it that Medicare is in a prevention mode. We are in prevention above all mode. Medicare finally gets it, that prevention is about 50% the cost of treatment. Sometimes we need to spend a little bit more money on prevention and doing better care to get those outcomes, but making sure we're educating that wounds and such skin problems are abnormal. Most people are not born with these situations or these diseases. Most people have beautiful, intact skin, and if we teach them, this is what is normal, this is what we want you to do. We want your skin to be soft, supple, intact, well hydrated, topically moisturized, and in so doing, we will help you prevent it from tearing, from getting pressure ulcers, from having issues that will cause all of these other things. Look at your national standards. Are you setting a national standard, or are you looking to others that might be setting a national standards that are going to be your benchmark to make sure you get the outcomes that you want? Incorporate in whatever disease entity or pathway or critical thinking or critical pathway avenue, whichever way you're doing this. If you have a specialty, we're going to deal with cardiac patients or ortho patients or rehab, some neuromuscular issues. Maybe we're just going to be in the palliative care arena, a mother, maternal child, or wellness programs, whatever they are. Remember, your skin and wound care programs, there will never be a separate pathway for that. These things will be incorporated in every single thing that you do. And in so doing, you're going to be able to improve outcomes, because every single disease entity has issues, either with their skin or with risk of developing wounds or problems. The meds they're taking because of a disease affect their skin. There's so many things that we can really help them with and really have much better outcomes. Be part of the process. What I'm finding in this decade or so that I've been traveling around the countryside is that a lot of staff doesn't realize who sets the standards where they work. They don't realize who develops their protocols and their formularies and goes through the evaluation process. Remember, this is not something given to you by government. The state surveyor isn't going to come in and say you have to care for patients like this or do it like that. They give you general information and standards of practice that you have to adhere to, but you decide how you're going to do that based on the population that you deal with. And that's why I really suggest everyone in this room should be part of that process. Get involved. How do we manage these things? How do we care for our patients? Okay, starting from the beginning, if any of you've never seen a wound care program, I apologize. We do like ugly pictures. Okay. And they always seems to fall before and after lunch for whatever. But you can see by the photo on the left, what a nice day to go in and sit down and visit with this patient. How are you doing? How are things going? Everything working out all right for you? You know, that's lovely. And we should all, hopefully we have time in our busy days to be able to do this a little bit. But if we have not also taken the next step and taken the time to do that comprehensive skin assessment, we might miss that ulcer on that gentleman's leg that was under his pajamas and under his sock, and he didn't think about it to tell you, and it doesn't, you know, that's not why he's in seeing you for whatever reason. This might be just an incidental finding. And you can see this ulcer is, you know, you don't have to be a wound care person to tell this is a problem wound. It's got necrotic tissue, it's got cellulitis, it's got edema, it's not doing very well. And if we just ignore it, what could happen to this patient? We could discharge him home, and he might come in back to our system or to an acute care system with a raging infection and maybe even be septic, and this could get into a limb or life-threatening situation. So things we want to pay attention to, you know, yes, it's great to do all of this other, making sure that taking care of all the other issues, but don't forget the skin and how important that comprehensive skin assessment takes less than 10 hours. 10 hours, oh brother, no wonder nobody does it, right? Less than 10 minutes in your day, all right? And if you don't find anything, you're just gonna be happy and keep on going on. Some of the other things, oh, by the way, is that lower leg wound a pressure ulcer? No, very good. All right, the top right there, I don't know if you can see this. Let me see if I can find a pointer. Yes, here we go. This is a buttocks fold right here. Okay, so what is the location of this problem? It's actually a hip, the greater trochanter, and this actually has, oops. Okay, where is it? There we go. This actually has bone exposed. So what are the concerns there? Osteomyelitis, exactly. Okay, we're gonna review this a little bit, but when you see bone or tendon, even muscle, you see body parts looking back at you, this is never good, all right? In any type of a wound, this is never ever good, and you have to be concerned. If you can see it or feel it or probe it, there's a likelihood that it already has osteomyelitis, and why that needs to be addressed. So because this wound might not ever heal until that is addressed. So get that taken care of. How about down here on the bottom left? Okay, it's on a hand and it's a skin tear. Is that something we would stage? No, okay? We know that, but what do? We cleanse it, we moisturize it, we secure it. You know, this is just the top layer of the skin that has torn back, and we want to try and get that layer reattached if at all possible, and somehow get it to stay together without doing harm to the skin. Teaching patients simple things. If you drink more fluids, you put moisturizers on your arms and legs twice a day, you protect your skin, this doesn't have to happen, okay? You can improve the integrity of the skin. As we get older, we don't have that cushioning and protection, but we can prevent these things from occurring. How about this wound here on the bottom right? A little more difficult, okay? Well, let's start with location. What is it? Left foot, okay? Is that normally where we would find a pressure ulcer? No, okay? So does anybody want to stage it? Use the staging system to describe it. No. Okay, so we're not going to use that. So now the next step is, what do we have? We have a problem below the knee. And when you have a lower leg problem, you want to do a lower leg assessment. All right, checking the pulses. And just like the skin risk assessment will take you less than 10 minutes to do every day, a lower extremity assessment only needs to be done if there's no wounds, about once a year. If there are wounds, about every 3 months. Okay, so it's not a great deal of time, but it helps you determine, is there something I can work with this patient for? Okay, so we're going to check the pulses, the popliteal, the femoral, the popliteal, the dorsalis, and posttibial bilaterally. While you're taking the pulses, pay attention. Do they diminish as they go distally? Is one side stronger than the other? What is the color, the temperature, the hair growth patterns, and the muscle wasting? All of these things are helping you determine, is the blood flow diminishing to that lower extremity, and might I need to get this patient some help? All right, it's not a pressure ulcer, so I'm not going to initiate my pressure ulcer prevention program, but maybe could this be a diabetic foot ulcer? Sure it could. Could it be an arterial problem? Could it be a cellulitis from an infection from some sort? Could it be from a bite? Could it be frostbite? Are there lots of things this could be? And if we ignore it or don't identify it, don't report our findings, you see where these things get missed, and then the patients can get into trouble. Simple things that we can do and get them to the resources in your community. We're going to talk briefly about the skin today. The largest organ of the body, that organ that protects us from everything going on around us. Our skin takes up about 15% of our ideal body weight. It takes up about 1/3 of our normal circulating blood volume. The normal temp of the skin is around 92. And we now understand, and this is something we have learned in just the last 5 to 7 years, that we can actually improve the integrity of the skin, not just by what we eat and drink, the ingredients we take in for nutrition and hydration, but also by what we put on it topically. And better products improve the integrity of the skin and give you better outcomes. Okay? We know that the skin is a little bit acid, and we have known this for decades. It doesn't matter when you went to school, we all learned this, that the skin had what was called an acid mantle. The pH is around 5, that helps to protect us from pathogens or bacteria that might be on our skin so that they don't become problematic. It also should be a reference for the type of products that you use. Why you don't want to use the old-fashioned bar soaps, the soaps that are very alkaline and strip the oils and lipids from the skin, just like we don't want to use hot waters. These things encourage problems with the skin and rinse off or wash off all the good stuff. We also don't want to use the old-fashioned acidic wound cleansers, because those types of things kill cells. So the days of bleach and vinegar and peroxide and all those crazy things that we used to use, we don't use them anymore because they are so harmful and kill cells. All right, we'll talk a little bit about the layers of the skin and why it is so important to look at the skin. When you identify someone is at risk, assess it every day. That epidermal, I'm not going to go into all this detail here, but just know that you want your patient's skin to look as good as yours. Is it soft? Is it supple? Is it intact? Or are there portals of entry for bacteria to invade? Or is that epidermis nice and intact? When the epidermis is removed or injured and we're down into the dermal layer, this is where we're now into a partial thickness or potentially stage 2 pressure ulcer. And why partial thickness or stage 2 pressure ulcers heal so quickly is because there is no structural damage. There is no injury to the support structures of that skin. And these wounds should heal up in a week or so, maybe 2 at the most. And remember, there's no structural damage damage. The skin is probably one of the most forgiving organs that we have, because our skin, even when we burn it, even when we pour hot water on it in a shower or a tub, we put harsh chemicals on it or strip the oils and lipids from it, whatever we're doing to it, it still is very kind, and every 28 days we get all new cells. It just keeps regenerating and giving us brand new cells again. When that top layer is gone, though, what happens, again, no structural damage. The collagen matrix is still there, the blood vessels are still there, and what they call the appendages, the sweat glands, oil glands, and hair follicles. And like all wounds, these wounds heal from the perimeter. There it is. And those little red dots that you see in the wound, those are what they call the appendages. And those also have epithelial cells around them. So they will fill in from all these different areas. So when you have a wound like this, if it's from pressure, it's a stage 2 or a partial thickness. If it is not, we cleanse it. We put a moisture retentive dressing or a barrier on there. We leave it alone. This should be closed in another week or so. These should not be the wounds that you are having problems with, getting them to close. Now, when we get down below the epidermal and dermal layer, now we're starting to get into the structure of the skin. And we're getting into the subcutaneous layer and below. And when these things are injured or destroyed, they never ever grow back. And this can be really a problem, and why these wounds are so much more difficult to heal and so much more difficult to maintain, because that structure is never as good. Now, we've learned many things about this part of the skin. First of all, we know, again, as we age, as we get into our 7th, 8th, and 9th decade of life, that little subcutaneous fat layer, that little cushion under our skin, most of us can feel that little pad there. Well, that's a protective cushion, if you will, so that when you bump your arm, bump your hand, or you hit it, you know, going into a room or something, someone takes your blood pressure, probably you don't get a bruise or your skin doesn't get torn. But you've seen people as they get older that they just hit their arm on the side rail or going into the restroom, or someone takes a blood pressure or they grab them and they rip their skin because they don't have that cushion and protection that they once did. Now, what we learned from the pressure ulcer folks about 5 years ago now, that remember, there are parts of our body, nobody in this room, none of the patients that you deal with, or no one in the world, no one has subcutaneous fat on certain parts of our bodies, like the back of our head, the bridge of our nose, the behind our ears, our elbows, knees, malleolar areas, but these areas are very bony protuberances, so that when the epidermal and dermal layer are damaged and removed, even though there is no depth, okay, or there's no fat depth there, it may be a full thickness or potentially stage 3 or 4 pressure ulcer. Doesn't have to have depth to be a full thickness injury, okay? Now, there are times when we do have parts of our bodies that do have more significant adiposity. That's how they describe it, or fat depth, okay? Some of us have more of those locations than we would like, okay? So what would be the location? Can you tell what this is? It's actually an abdomen. It's a surgical wound, okay? This is the subcutaneous fat. You see, fat looks like fat. If you've never seen fat before, looks like chicken fat, beef fat, whatever. It all looks the same. This is and this is a surgical wound on an abdomen. Now, is this a pressure point? Are we going to stage it? No. Okay, so we're going to forget about the staging system. Now we're going to go, this is a full thickness problem. We're going to do our wound bed preparation and get this wound closed in a timely fashion. Remember that a wound is any injury to the skin, and we may or may not be able to see it. This is so important when you're doing your skin risk assessments, why we don't just visibly look at our patients anymore. We feel all their bony prominences, especially with the suspect deep tissue information that we understand now. Remember, it may be 3 to 5 days before you visibly see something on that skin. And then what happens is in your institutions or your healthcare settings, you have to take credit for it, when maybe it started somewhere else. Maybe it started in their home, or after a motor vehicle accident, they were laying on the highway, or on an OR table, or someplace else, but not in your particular setting. Again, why we assess this carefully. Know the difference in how wounds close. Partial thickness wounds will close up very quickly. They re-epithelialize, they regenerate. There is no evidence they were there before. There's no scar tissue. Full thickness wounds are the wounds that are the problems. As they fill in and contract, the cells migrate across that surface. You now have what becomes the closed wound, which is the scar. And that tissue is never as strong as the original tissue was. These wounds should close. We now understand this time to wound closure. The wound repair, wounds should be closed in about a month. And if that's not happening, what are we doing to make sure it's not our care or lack of assessment that has caused that patient to have delay? Okay, let's review the phases of wound healing. Some people say there's 4 phases, some people say there's 3. You pick what you like. Remember that our bodies are always smarter than any scientist, the smartest person you know. Our bodies are smarter than that person, because our bodies know exactly what they need to get better. They know what they need to close wounds and to do things. What we have to be, remember, we are not wound healers. We are not people that heal wounds. We are critical. We are the people looking at these patients and assessing what it is that they need to get better. So we need to know what is the normal process for these things to happen, right? That's what we were all taught in school, is normals, so that when something wasn't happening the way we thought it should or the way we expected it to, what do we need to fix to get it to go forward? All right, so the body's injured, and this will happen to every person with any kind of wound. All right, the body's injured, the body's alerted it has an injury. If there is bleeding, it will send cells to that wounded area to start the clotting mechanism. This should last about 15 minutes or less, so you're not hemorrhaging. That's what has to happen. Some people say that's part of the inflammatory process. You pick what you like. Okay? In the inflammatory phase, so this should last only about 5 days. And again, all wounds in all patients will do this, except for one situation. And what would that be? You probably deal with some of these patients. People who are immunocompromised. And you would know that, right? Because of your comprehensive assessment. They have a disease that is affecting their immune system. They are on medications that are affecting their immune system. They may not be able to incite a normal inflammatory response. I want to know that. I want to know that's the reason this wound or this problem is not doing what I expect it to do. Okay, but we're going to pretend everybody's normal today, right? So we've got a normal inflammatory response, and what happens then? The body, again, sends cells to that wounded area to start the wound repair process. Sends those enzymes and white cells and red cells and all the things that the body needs to start that wound bed preparation to get that wound cleaned up and get it closed in a timely fashion. Okay, the symptoms you will observe in these wounds, there will be some peri-wound erythema. That should only last for about 5 days. There might be an increase in exudate or drainage. There will be an increase in warmth, and there might be some pain. Sometimes acute wounds are more painful than chronic wounds, but we all know that chronic wounds can have pain as well. All right, so if I was admitting this patient to wherever you work, okay, and the photo on the left there, I'm doing my comprehensive skin assessment. I take off their clothes, I'm looking at all of their skin, and I find this wound. What would be a question I would want to ask this patient? Okay, I will tell you, well, we would be seeing that, okay? This is, I will tell you, I'll give you some information. This patient is, or this is a burn on a patient. She burnt her hip with a heating pad. And what she did was she left it open to the air. What her grandma taught her decades ago was to leave the wound open to the air. That's what people used to think, that the wound had lungs and it would breathe and somehow it would get better with that. We know now there are no lungs in wound beds, and so we don't do that anymore, okay? But this, what beyond that, what would you want to know? How long has it been there? Okay, I want to know, is this normal inflammation or is this wound getting stalled, right? So I will tell you this burn is 3 days old. For those of you who can't see, this is black eschar here, compressed dead cells in the center, and then this is normal peri-wound erythema that has come there to try and clean up that wound bed. So we help the wound bed along a little bit. We cleanse the wound, we put a moisture retentive dressing on, we sent the patient home for a week, and came back a week later, and this is what the wound looked like. We took the dressing off, irrigated the wound. You can see that the eschar is gone. Can you see that the peri-wound erythema is gone? Can you see that the wound is also a little bit larger from one side to the next? Okay, at this point in time, that is normal. Just something to understand. When I'm first cleaning up a wound, and especially one with a lot of necrotic tissue, that might get bigger. If a wound continues to get larger or doesn't change in size when I'm doing my wound care, that tells me either my wound care is not helping the wound or something else is wrong with that patient, and I might need to get further assessment. All right, are these symptoms I'm expecting in a normal inflammatory response? Or is this patient, are we now going into the next phase of wound healing? And that's where we get a full thickness or stage 3 or 4 pressure ulcer. Okay, when you have a wound, in the inflammatory phase, all wounds will go through that. Partial thickness or stage 2, they are now done. They are now almost closed or completely closed, and now we're going to go into a wound that is a full thickness wound, all right, or potentially stage 3 or 4 pressure ulcer. And remember, now we're down into the structure, the sub-Q, the muscle, the tendon, the bone. This tissue never ever grows back. This tissue is never as strong as the original tissue was, which is why these wounds can be so difficult and why we want to pay close attention to them to get them closed quickly and then educate the patient on the importance of not allowing this to break down again. What is the pressure ulcer prevention care you've educated them about? What is the diabetic foot care you have educated them about? What is the venous leg care you have taught them about? The skin tears, whatever type of wounds that you are dealing with. So this is now where the wound is going to fill in with different tissue. And at first it fills in with granulation tissue. And that will start to fill in that defect or hole. That will now stimulate contraction. Okay, and do you remember when the contraction phase starts? Day 7 through 10 in wound healing. And so as the wound is filling in and the edges are starting to contract, that's so the epithelial cells can migrate across a flat surface. That's the way epithelial cells migrate fastest and best, is when they can migrate one to the next as they crawl across that flat surface. When there is no flat surface to crawl across, okay, when there is a hole there, epithelial cells can't jump in a hole. They can't jump off a cliff and dive into your wound beds. That's not the way they work. They need that flat surface filled in for them to close more quickly. All right, oh, excuse me. So when you add the inflammatory phase, which should last about 5 days, to the proliferative phase, which should last about 25 days, 5 plus 25 equals what? There's your 30 days till closure. Now, in the past, when a wound had filled in, contracted, the cells migrated across, they came in contact with one another, that's called contact inhibition. Wound is now closed up very nicely. In the past, when a wound was closed, what did we used to say it was? Healed, because we forgot about the healing phase, the maturation phase, the remodeling phase, understanding that these full thickness or stage 3 or 4 pressure ulcers take upwards of 2 years to completely heal. These wounds aren't healed when they're closed. It takes a while for this process to get as strong as it's going to get. And it's never, ever as good as the original tissue was. In fact, the tensile strength of that scar is only about 70% if it's only injured one time, which is again what makes these patients always at risk of breaking down. Okay, so why we want to focus on these things and make sure we help them. Now, when we're talking about pressure ulcers, remember, pressure ulcers are usually over bony prominences. We have some exceptions now. Why we assess so carefully not only for pressure and pressure redistribution, but also for friction and shear issues, because the way a patient sits in a chair or their bed is the way that what causes issues with friction and shear. And we know that friction and shear are what make pressure ulcers worse, what causes the undermining and or tunneling. Remember now, you also have to count these device-related pressure ulcers and mucosal membrane pressure ulcers when you're looking at your staging and the things that you have to report to the state. All right, there's some information on the MPUAP website if you need that. Okay, remember to call wounds by the location they are over. We call pressure ulcers by the bony prominence that they are over, not the general location, not the buttocks fold, not the hip, not the upper thigh. We call it the ischial tuberosity if it's there, what you're sitting on, the greater trochanter, the actual heel or the malleolar area, whatever that bony prominence might be. So we understand here's the bone, here's the problem with the pressure, and here is how we're going to identify it. Understanding that pressure ulcers start usually down here at the bone, and as that tissue is squished against that bone, we have an ischemic event, death of tissue due to lack of blood flow. And as this ischemic event is evolving through the layers of skin, why it is so important not to just visibly look at the patient's skin, but to feel all those bony prominences to make sure you identify, is there something different one side to the other, and is this patient getting into trouble? Is there something there I need to keep an eye on and prevent it from getting worse if at all possible? Know that the NPUAB staging system is only intended for describing pressure ulcers. It is not intended for any other type of classification of wounds. And it's important for you and your staff to understand, if you don't know, don't guess. Don't make things up. Your medical records, your billers, your coders, the people you work with that look at your documentation, your legal staff, risk manager, quality folks, everyone involved in this process will tell you they would much rather you say, I don't know what this is, but this is what it looks like, and this is where it is, and I'm not quite sure what I'm expecting. And that way then you get your wound care people or your experts over to help you with that. Okay, so let's briefly review the staging system. Again, trying to simplify it and demystify it. What is a stage 1? Well, this is an area over a bony usually over a bony prominence. That word was added 5 years ago. Intact skin with non-blanchable redness may be more difficult to assess in darker skinned individuals. What they did add 5 years ago were these further descriptors. The area may be painful. So before you see anything, the patient might tell you what? This heel hurts. It hurts for me. I can't sit on this. I can't lie on this. Or if they're not able to communicate with you verbally, that patient that every time you position them in one way, you get back in there and they've moved, or they're always wiggling off that side or something, maybe it's because they're uncomfortable and that's their method of communication with you. Okay? The area, when you're feeling it, it's firmer, it's cooler, it's hotter, it's colder. It's different one side to the other, and someone we need to pay attention to. Is it someone that just has the concern with reactive hyperemia, where when that pressure is relieved, the blood rushes there, but that will go away very quickly? Is it actually blanchable? Is it non-blanchable? Now we're hearing about a new term called pre-stage 1, where this was invented by a physical therapist she was having trouble with her staff in their staging, and especially when they were looking at stage 1 problems or problems that maybe were a problem but weren't. And when they would call it reactive hyperemia or blanchable erythema or non-blanchable or whatever the terms, then they wouldn't do anything else. They would just ignore the patient and not follow up. And she found that by calling that area a pre-stage 1, this is a potential pressure ulcer. This is something I'm worried about. And good for you, good for the patient if nothing else happens. But if it does, good for us that we followed up on it and took the steps necessary. This unblanchable redness, we've got to get them on turning schedules, address this. Is this going to become a further problem, or can we stop it at this point? Okay, remembering that dark-skinned individuals are more difficult to assess. Not that they don't blanch, that they don't have issues, but visibly we can't see them as easily. Okay, stage 2. Now this is the one, the MPUAP gives us a lot of good data in this staging definition. Okay, partial thickness loss of dermis presents as a shallow open ulcer with a red-pink wound bed without slough. Notice it doesn't say granulation tissue. It talks about a red-pink wound bed and no slough, no necrotic tissue. May also present as an intact or open ruptured serum-filled blister. So now we have this definition of exactly what it should look like. The further descriptors go on. Remember, it can present as a shiny dry ulcer without slough. They're emphasizing no necrotic tissue or bruising. And they asterisk bruising. Bruising may be an indication of suspect deeper tissue injury. They are not saying all bruises are suspect deep tissue injury, okay, but a bruise-like appearance, usually over a bony prominence. Then they go on to tell us this stage should not be used to describe. So in other words, do not stage skin that has torn, problems with the skin from tape burns or tape blisters, perineal dermatitis, excoriation, or maceration. Now this has gone to be a more encompassing term called moisture-associated dermatitis, that we understand we do not stage moisture problems. These are problems we fix with skincare. They should resolve very quickly in a week or two, but we do not stage them. They, again, very partial thickness injuries, just the epidermis is off of that area, can be from friction, whatever, or it actually could be from some pressure. We cleanse this area. You can see the little, I don't know if you can see that very clearly, but the little dots in that wound bed. And as these bridges of skin are starting to fill in all over the place, and you cleanse this, you put a barrier on it or a moisture retentive dressing, keep them off of this, address friction with scrubbing, address friction with positioning, and we should improve this in a week or so. This should be closed up. These, again, should not be the difficult wounds for us to manage. That as they fill in, they may have multiple small areas because of all the different surfaces that are epithelializing. These are just some helpful hints. These are things that can be, especially for new people looking at the skin. Don't know, some of them don't know where to start. This still isn't taught in nursing school. This still isn't taught in medical school. It's the only people that get skin and wound care in their core curriculum are physical therapists. So, you know, any helpful hints we can give them to make it easier. Remember, you cannot have necrotic tissue in a partial thickness or stage 2 pressure ulcer. When necrotic tissue is debrided, what fills in? Granulation tissue that contracts and reepithelializes. Okay, that doesn't happen in a partial thickness wound. They don't have granulation tissue. And that open, flat edge where the cells are just crawling across and closing very, very quickly. Remember, that's how epithelial cells migrate fastest and best when we use those moisture retentive dressings or barriers. All right, now let's take the next step. What is suspect deep tissue injury? Well, compared to that superficial partial thickness injury, now we are talking about a bruise-like appearance or blood-filled blister due to damage to soft tissue from pressure and or shear. Why we assess for that so carefully. Just like in a stage 1, this area may be preceded by tissue that is painful, firm, mushy, boggy, hotter, colder, whatever, different one side to the other. This is warm or firm. This feels pretty normal. This is different. There must be something brewing here. And remember that deep tissue injuries, like a stage 1, may be more difficult to assess in a darker skinned individual, but these wounds are in evolution, and that these blood-filled blisters may evolve over that dark wound bed and become covered with that thin eschar despite optimal treatment. So even when you're doing the best care and providing excellent care, we know these wounds are in evolution. Okay? They may start out, you may not even have this blood-filled blister, right? It may just be painful. It may be something that is mushy, is firm, is boggy, and then that blood-filled blister shows up. We call that what? Suspect deep tissue injury, and these wounds are evolving and they may become covered with an eschar, and then what are they called? Unstageable. All right, and a stable eschar, what do? We keep it intact. We keep it in place. So understanding what is happening with these problems. Okay, stage 3 and stage 4 pressure ulcers, the definitions have never changed. What we learned in the 80s, 90s, and this new century, it's all the same. Full thickness tissue loss. Subcu fat may be visible, but bone, tendon, or muscle are not exposed. Slough may be present, but doesn't obscure the depth of the wound, and you could have undermines and tunnels. Remember, the further descriptors, the depth of a stage 3 depends on where it's located. They teach us there are parts of our bodies don't have subcu fat. Remember, like the back of our head and the bridge of our nose don't have subcu fat. So when the epidermal and dermal layer are damaged and removed, it may be a very shallow stage 3 or stage 4 pressure ulcer. But in contrast, if it were on a greater trochanter, an ischial tuberosity, there might be significant adiposity or more fat depth, and you might have a deeper wound. Bone and tendon is not visible or directly palpable. Okay? In contrast, a stage 4 takes it the next step, right? Full thickness loss, exposed bone, tendon, or muscle. Okay, those aren't present in a 3, they are in a 4. Slough or eschar could be there, often undermine and tunnels. Again, the depth of a stage 4 depends on where it's located. Remember, there's parts of our bodies don't have subcu fat, could be very shallow, and stage 4 ulcers can extend into muscle and or joint capsules, making osteomyelitis possible. And we know what? If there is bone, tendon, muscle, you can see it, feel it, or probe it greater than 50% of the time, the osteo is already there. So get it assessed, get it treated, get it taken care of. Okay? If you can see these things, you know you've got a stage 4. Okay, you can see what the location is on the sacrum. And we've got a muscle, you've got some granulation, you've got some necrotic tissue. We need to do our wound bed prep and get this wound going, right? How about this one? Location? Ischial tuberosities, very good. Bilateral, this one is to, that's muscle, and this one probes to bone. So bilateral stage 4 ischial tuberosities, and then do your complete assessment. What does unstageable mean? Does it mean it is not a pressure ulcer? No. Very good. I will guarantee you there are people you work with, staff members, that believe when I write down unstageable, unable to stage, or not stageable, that means it is not a pressure ulcer. They don't understand that unstageable means it's full thickness. It's at least a 3, it may be a 4, in which the base is covered with slough or eschar. And until the slough or eschar is exposed or debrided, right, the true depth and therefore stage cannot be determined. It is at least a 3 or 4. Remembering, it says it right here, stable eschar on the heels serves as the body's natural cover and should not be removed. Okay? So you've got that. Can you tell the location of that? It's on the hip, the right greater trochanter. What would we say about this? It's covered with necrotic tissue. Unstageable, which means what? I need to get it debrided. I know it's a 3, it could be a 4, right? Okay, how about this one? Gross, yes. Location? Right ischial tuberosity, full of slough and necrotic tissue, unstageable? Right. Okay, just to clarify, can you tell that that's a blood-filled blister? Yeah. Okay, so what do we call that? Suspect deep tissue injury. Do you understand that these wounds are evolving and may become covered with an eschar, and then they are unstageable and we keep them stable and intact? Right? Same with this one here. Blood-filled blister on the heel becomes covered with an eschar. It's a very normal progression of these wounds, even when you're doing the right care. Okay? And that's what happens to them. All right. Remember to look at your lower extremities. Pay attention. These are not wounds that we assess. We want to make sure we differentiate if we're not sure of the etiology. The most common wound you will see is a venous leg ulcer. This is something in the distal third of the lower extremity that we treat with compression. This is the only disease that has skin manifestations. So very easy things to kind of pinpoint us that way. Arterial ulcers, people with PVD, PAD, heart conditions, previous strokes, carotid issues, atrial fib. They could be having problems with their lower extremity. Again, not something we stage, we just call them what they are. And then the neuropathic or diabetic lesions, these are abnormal foot conditions. We do not stage these either. You've got lots of terms out there with the Wagner scale and University of Texas, if that's of interest to you. There are times when pain is a good thing. Talking to hospice nurses and palliative care nurses, you know about these things, but these are not enhanced photos, but know when people don't feel things, it is amazing what you will find. This was actually a nail they didn't know was in their foot. This was an incidental finding on x-ray, by the way, of a sewing needle. Okay, they were just doing a screening x-ray on a new patient with diabetes and found a sewing needle in his foot. So in review, your skin and wound care management, the programs that you have to address skin and wound care issues can be some of the easiest ways to be more cost-effective, have better outcomes, know how these wounds heal and what the expectations are. Let's talk about wounds being healed. When we know we've done that fabulous job, we've gotten this closed in a timely fashion, and we've educated them on the importance of prevention, that we're not going to have pressure ulcers, we're not going to have the skin tearing, diabetic foot ulcers, venous leg ulcers, whatever the etiology might be, so that they have this beautiful intact skin. And that will be my final thoughts. Any questions? Yes?
You've staged your ulcer, and it's a 4, and you're documenting the healing. You don't down stage.
Correct.
The wound.
Correct.
You just, how do you
It is a
document
healing stage 4.
a healing stage
Healing
4?
or remodeling, research, whatever term you use.
Remodeling.
The question for those that might not have heard it is when we have a stage, and this is true, a stage 4 especially, the worst a pressure ulcer was, it is forevermore. Okay? We don't grow back that original tissue. A 4 doesn't become a 3, then become a 2, and then become a 1. A 4 fills in with granulation tissue, contracts. It is now a scar, and that scar is a healed or remodeled stage 4. Okay? A 3 is the same way. Now, a stage 3 can do what? It can get worse. It can become a 4, but it can never become a 2. It can never become a 1. All right? It doesn't grow back that tissue. Full thickness stage 3 or 4 pressure ulcers don't do that. Now, stage 2s become what? Well, you're right. 1s and 2s can become 3. They can get worse. They can always get worse. And the worse they are forevermore. Okay? Once you're a 4, you're always a 4. And how long do we have pressure ulcers? Until the day we die. They never, ever, ever go away. That's why when you're doing your skin risk assessment, you're counting those scars, that healed stage 4, because that patient's skin is at risk of breaking down. Remember, if it only broke down one time, it's only 70% of that original strength. It's always at risk. Why we're going to teach them that, okay? But it doesn't grow back. That's why the reverse staging went away, okay? Anyone else?
Whoops. Thank
Yes.
you. So,
We got one more, okay? You have time for one more?
one more.
Okay.
Hi, we have a resident who the surgeons have decided that her stage 4s will never heal. How do you
Okay.
handle that as far as treatment?
Is this in a hospice situation? Palliative care?
She's not hospice yet, no.
Okay. And is it because of all the risk factors and comorbidity? And I need to know a little bit more.
It's the lack of circulation that she has down to
Okay.
her feet.
Oh, so they're on her feet. Where are they?
One is on her heel of one foot, and the other is on the, what would you say, lateral aspect? Yeah, like the lateral aspect of her small toe above it.
Okay. I would probably guess that those are probably more related to arterial ulcers and lack of blood flow, and then the treatment options are different. You don't want to keep those optimally moist. You want to let them dry out. Keep them clean and dry, free of trauma and free of infection. Keep them keep them from getting worse. Okay? And you can look at one of the guidelines. Do you work with a WOC nurse? Do you know a WOC?
I don't believe there's been one to see her. There was
Okay.
one to see a different patient.
Okay, you can go on WOCN.org, and there are guidelines on pressure ulcer care and lower extremity care, and you could access those as an appropriate resource if you don't have access to your own WOC.
Thank
Okay,
you.
those are readily available. The negative pressure wound therapy is a great option when appropriate. Just another device.
Let's give Joyce a big thank you.
Okay, thank you. So turn this off or just leave it?